Welcome to the Hair Loss Show. Dr. Russell Knudsen and Dr. Vikram Jayaprakash discuss issues relating to hair loss and the medical and surgical treatment of hair loss in both men and women.
Hello everybody, welcome to the Hair Loss Show episode 29. I'm Dr. Russell Knudsen.
And I'm Dr. Vikram Jayaprakash. Welcome back. We thought we'd do another one of our case studies.
So a mock consultation, if you like.
That's right.
Where we look at how we would go about offering advice and assessing a patient that came to us.
Yeah. So again, we've got pictures of patients that are patients of ours, and we thought we'd just take you through that and how we'd manage these individuals and what are the things that we need to consider and take into account. So we have this gentleman here who's 46, has been losing hair over the past 15 odd years. All his brothers and his father are equally bald. He's probably not lost a huge amount of hair. There's been a little bit of thinning over the last 12 months, but not a huge amount. But he's got to the point where, you know, you can see he's doing a little bit of a comb over on the top of the scalp and is not happy with that. And he's been cogitating over the whole thing for many years now, and he's reached a point where he's gone, listen, I'm not happy with the way my hair is. I want to do something more permanent and proactive about this. And he wants more hair on the top of his scalp.
Well, that's the important thing, because one of the first questions I say to patients when they come in for the consultation is, largely speaking, the patients fall into two categories. Those who are okay with where they are, they just don't want it to get worse. Well, that's a medication pathway. And then there are the people like this that come in and say, well, obviously I wouldn't like it to get worse, but I really want it to be significantly better. And in someone like this particular patient, that's going to require surgery as well. Now, as Vikram said, luckily he's already on finasteride. That seems to be working pretty well. So to have a look at this, if you look at this particular picture here, you can see, if you understand again the Norwood system, this is a Norwood 5A, meaning it extends from the front through into the crown in a relatively high pattern. It's not very wide out to the side here. One of the things I really want to point out to you, looking at the photo, is we discussed in our episode on miniaturization how one of the things of miniaturization is that the hair loses pigmentation. Well, this is like a piebald here, because you can see, even though he's a sandy blonde, he's much darker here than he is in these hairs. So these hairs are significantly miniaturized, which is why, and down here, even in the preauricular, the area here around the pretemporal area, you can see that the hairs are depigmented, and he's doing the comb over to try and cover up the loss of hair on the top there. But it's a very good example of what we talked about, how miniaturizing hairs depigment. So essentially for him, I'm going to be a little bit led by what he's asking for, okay? Because if he comes in and says, well, you know, I want it to be thicker on the front, and I said, then I would say to him, well, just how far forward do you want it to be thicker? I don't presume that he wants to take it back to the original point.
This is the important part, because we've talked about, if you're looking at hairline design, for most men that are losing hair, most men that have a hairline, the lower part of the hairline actually divides the face into thirds. The thing to consider here with this gentleman is, yes, that's the case, and maybe that point is, you know, roughly arbitrarily here. There's no right or wrong answer here. I mean, yes, we don't want to go lower than that, but the question is, and this is where we'll be led by the patient, is where does he want the hairline to be? Because we don't necessarily need to bring it down. We want to do what makes him happy.
If you're asking about the visual impact of where you draw the hairline, where it should be, the best way to describe it simply is that if you look in this photo, you can see the forehead in the lower part is basically vertical. Then there is an area where it becomes oblique, meaning it slopes backwards, and then there is an area where it becomes horizontal, which is back here. Right? At this point we're horizontal. At this point we're in the oblique, and at this point down to here, right? To here is vertical, and to here is horizontal. So the hairline, whatever you choose, if you want to have it optically looking like a good outcome, it's got to be somewhere on that slope, okay? If you put it back here, visually from the front it looks like a flat line. It doesn't look right. If you put it down here, you are really taking it way back to where it was before, which may or may not be a good idea. So typically we're going to suggest to patients they come forward, but I never assume that I know what they're thinking. I ask their opinion first, and then we talk about it from there.
Yeah. So first things first, we want to make sure he's stable. He's on finasteride. He's stable with that, and then we put it to our our patient. Well, what is what does he want, and what were his requirements in terms of hairlines? And this specifically for this gentleman, he was quite conservative. Didn't want a very low hairline, because the other thing is that once it grows, it makes a big difference from where you're starting to where things were going to be in 12 months' time. So you've got to factor that in, and it's sometimes it's the subtle changes that are all that are required.
Now there's one specific thing that I'm going to mention about this particular patient, which is going to be relevant for him, not necessarily for many others. There is a very big colour differential between his hair in his back part of the scalp and the hair on the top of the scalp. We're using these hairs. Guess what colour they're going to be? This colour. So sometimes patients say to me, like, the hair, my surrounding hairs are much lighter, and I'll put these grafts in and they're so much darker. What can I do about it? I'm going, well, that's what the healthy hairs look like from the back of the scalp. So if you prefer the colour you've got on the top of the scalp, you're going to have to dye them back to that colour. Or you're going to have the surrounding hairs dyed up to the colour of the grafts. Now that doesn't happen to many of our patients, but it certainly happens to our strawberry blonde patients occasionally, and maybe even our red-haired patients, depending on the degree of miniaturisation. So just be aware, when you take the graft from here and put it here, that's the colour we're looking at, not that colour.
When we're looking at hairline design as well, we talked about, let's pick an arbitrary point. If you're looking at this as from the top of the hairline, if we look at this point here as an arbitrary point as the low midpoint of the hairline, again, we've talked about how a hairline should be in a mature individual, someone in their 40s and 50s and so on. It shouldn't be flat. It should curve. Everything has curves. So you want to, if you're wanting to do that, we would recommend this gentleman create a hairline that sort of curves up and then joins the corners on both sides.
I mean, in the older patients, because so many of their peers have got significant recession, it's unusual for us to do low hairlines, right? We tend to have nice receded hairlines in those patients because that's more age appropriate. So again, we assess the patient's desires, we assess the shape of the forehead. The shape of the forehead also influences the design. Some people have narrow foreheads, so it'll be more like a narrow design. Some people have broad foreheads, so there's going to be a broad design in the middle third and then a little bit of recession. So it's not like we have a stamp and we put the stamp on the forehead and say, there's the Knudsen, there's the Jayaprakash hairline. It doesn't work like that. No. It's got to be customised to every individual person according to what A, they want, and B, what looks appropriate in terms of balance and taking into the facial geometry, if you like, the shapes into account.
All right. So I'm gonna ask you a question now. Okay. All right. So I mean, I know the answer in the sense that this gentleman wanted the area filled in. This top part, he wants good density throughout. They all do. And we operated on him. It took just a little over 2,900 grafts. Okay. So we needed 2,900 grafts, and that was within the expectation of what we predicted he would require. So we knew it was going to be somewhere between 2,800 to 3,000 to fill that area. Now, looking at this individual, he then asked, what technique would you suggest in terms of FUT or FUE? Be mindful that he is in his 40s, okay? He's got blondish, brownish blonde hair. Do you have a preference in what you would suggest for him?
I think his age is a factor for this. If he was 26,
yes,
I would say strip to begin with, and FUE later on to top up, because the younger the patient, the harder it is to predict what their eventual balding is going to be. And the difference between FUE and strip is in strip you're taking 100% of the hairs out of a much smaller area. In FUE you're taking 20 to 25% of the hairs out of a much larger area. And if you don't know how the baldness is going to progress is much harder to predict in a younger patient than I would be trying to stay a long, long way away from a balding margin. In young men that only have temporal recession and nothing in the crown, doesn't matter. It's an academic argument. But in someone who's got thinning extending back towards the crown, this area, even if they medicate, may continue to enlarge. So the younger the patient, the more conservative I'm going to be about what's a safe donor area. Him doesn't matter. So
Yes, I know. I think we gave him the option. He went for strip. All right. I think he made the decision for strip because we took 100% of the area from the
and it's immediately covers up because it doesn't require a shave on
and
the back
that was
of the
the
head.
key for him. He didn't want a long
secret
period.
men's business.
That's
approach, right. So he didn't want to have this shaved head, 1 millimetre of hair on the back of the head with scabs on it for a week. That was visible from
the other
behind.
thing, and this is a bit of a generalization, when we get close to that 3,000 mark with FUE, I'm being the conservative soul that I am, I'm always worried about the density with which we're harvesting from a large area.
Which could make it see-through.
That's right.
We don't want to transfer the baldness from the upper scalp to the lower scalp by over-harvesting the area. And that's a critical thing because it isn't just a numbers game. I mean, people come to me and say, I've been told I need 5,000 grafts, I've been told I need 4,000 grafts. Remember, how it's going to look afterwards, not just up here, but on the back of the head, depends also upon what kind of hairs we're talking about. Are they fine hairs? Are they coarse hairs? Do you have low, medium density? Do you have high density? All of these things make a difference to the visual outcome. All right, so again, I can't emphasize to you enough how important it is to get eyeballs physically on your donor area as well as your recipient area to make a good decision about what the appropriate way is to go forward. Because if you just think it's a numbers game, we see so many tragic cases now of people who've got very nice growth on the upper scalp, but a moth-eaten look in the lower scalp, and they come to us and say, well, can you put some hair in there? And I say, where am I going to take them from? Body hair. Well, yeah, maybe. Body hair isn't that great an example, by the way. That's really last resort, and they don't necessarily grow very well. So what we're often having to resort to doing tattoos, superficial tattoos in the donor area to help these people, because now they've transferred their baldness tragically from the top of their head to the back of the head because of this over-harvesting. So take-home message is more isn't necessarily better.
If just a quick question on that, let's just say paler skin and black hair.
Mm-hmm.
How keen would you be for FUE? I'll be a lot less keen because the color differential is such that when you take large numbers, say in that 3,000 ballpark, then you're really worried about that see-through moth-eaten look becoming more apparent.
That's right. So the colour contrast between the hair colour and skin colour does influence it. So don't get caught up in the numbers game. More sounds better. It sounds as if you're going to get a better result. But if you transfer the problem from the top of your head to the back of your head, that's not a good result. So, the thing about the graph numbers, just to be a bit specific about that, look, you can go to 4 different clinics and get 4 different numbers. Probably for a multitude of reasons. But one of the reasons that's true when you talk to someone like us is it really depends upon where you draw the hairline. Okay, if you draw the hairline higher, it's a smaller area, it takes less grafts. If you draw the hairline lower, it's a bigger area, it takes more grafts. Again, this is a customization approach. And again, that's extremely difficult to do by photos or by video because you can't sit and draw on the patient's head what the hairline would look like so they get a feel for what they would want, right? So I find it very hard, and I always say to the people that are having their consultations with me on video or by email, that this is just a general approximation because until I see you and work out what you're prepared to accept as a hairline, then I really don't know the number. And so, beware of these people who are very specific about how many grafts you need or promise infinite number of grafts. Because there's no such thing. You can take too much off the back of the head. And the balder you are, this is the other thing to remember, the balder you are, the less donor hair you have to move around. So the less donor hair you have to move around, the more conservative approach you have to
Being
apply.
conservative is key. I mean, the other thing I'd mention about that is that when we quote someone, potential graft number, I always say to people, that's just a guess based on what we've got. Like you said, it depends on where you draw that hairline. Every millimetre higher or lower changes the number of grafts. Also, what we're doing, if I say, oh, it's going to be 2,500 grafts, that's not a goal. That's not an end point. What we're doing is we're trying to, this one, yes, we have to rebuild this frontal area here, but he's got hair in that area. So we're picking the gaps between that to create that, illusion of fuller density. And so sometimes, we will give you, you'll get a number, but more is not always better because it's what you're taking from back there.
Here's something else. If you look at Vikram and myself, Vikram has black hair with a high colour contrast with his skin colour. I have silver white hair with pale skin. So less grafts on me would look fine compared to on Vikram. He would need more grafts to get the same kind of visual density because of the colour contrast that I would to get an adequate result. So this is another thing that factors into numbers, right? Some people come to us with a budget, right, and say, well, I've got X dollars to spend, what you can do for me, and then we try and work on that. So, or they can do it in stages. That's another way that some people do it. So, for example, if someone came in really, really bald and I needed 3,000 grafts up the front, but they had a big bald crown as well, and I'd suggest to them maybe we just do the front first, let that grow out, make sure they're happy with it, like a year later. If they're happy with it at the front, then we can talk about the crown. Because if the front is more important than the crown to them, then I want to make sure they're happy with the front before I'm going to sacrifice more.
Or vice versa. There's no right or wrong. Yeah, so they may go, oh, look, you know what? Let's fill this area in and make sure we're happy with that. And then in the future, we can now bring the hairline lower. So there's no right or wrong answer there. It's either one works.
We think there's 6,000 to 8,000 grafts in most of our patients. Okay, so that's the number we have. So again, if you think there's only 6,000 grafts in your patient, why would you use 5,000 at once, right? And so any clinic that's offering you 5,000 grafts as a starting point, first tells me two things. First, you've got a big bald area. So if you've got a big bald area, you don't have a big donor area. If you're going to use 5,000 grafts in a single operation, you're going to use up most of your available donor. There's not going to be a lot left for future loss or to achieve goals of increased density.
So that's making the assumption that we're talking, comparing apples with apples. Some people don't always say 5,000 grafts; they mean 5,000 hairs, right. And that's the other thing. And that's probably something that we should probably touch on at a later date in terms of terminology, the difference between a hair and a graft. Yes. But that's the thing that I
simply the graft for us is a natural occurring group of the follicular unit, which is 1, 2, or 3 hairs. All right, so it averages to a little bit over 2 hairs per graft. So when you listen and someone says 5,000, are they talking 5,000 hairs, which is 2,500 grafts, or are they talking 5,000 grafts, which is pretty much 10,000 hairs?
Good.
Okay, so I hope this has helped you understand how a consultation would be approached if someone was looking at, to give you options so that you can understand, and as I said, it's a complicated path, right? There's a lot of information to take in with a consultation. We try to get our consultations done in about 30 minutes because it takes a while to explain things to people, and we certainly expect them to go home and think about it, and if they've got more questions, to ask us about it. This is not a decision that is made as a snap decisions with a snap judgment. You get your information, you think carefully about it. If you need further information, you certainly should go back to whoever you saw and get that further information and make sure that you feel comfortable that you've got enough information to make a good decision that you're going to be happy with.
Yeah, this is not a substitute for you getting your own advice. Hopefully you've seen things here that may be applicable to you, that may be of interest to you, but and you can use that, but it's not a substitute from actually seeing someone who's trained to have a look at this and give you a formal assessment as to how to manage your hair loss journey.
Yeah, and you should never meet the surgeon in the theatre for the first time. Okay, that really is a bad way. The consultation should be with the doctor before the surgery starts.
Because ideally you want the decision to operate to be driven by the right factors, what your expectations are, what is achievable, and what's best for you in the long term, not what the bottom line will be for.
Well, one of the big things that worries us is we can have very, very successful operations but have unhappy patients. Now, why would that be the case? Well, the operation could be a success, but if it doesn't meet the patient's expectations, you've got an unhappy patient. Right? So a successful operation can be a technical success with a cosmetic failure to the patient if we haven't met their expectations. And that's why the doctor having a consultation with the patient allows both of them to understand what their viewpoint is, where they're coming from. And if they think they're on the same page, if they think that they're talking about the same thing, then that probably is going to work quite well. But if we talk to people, for example, and we have this experience occasionally, where we just don't think we're getting through to them, that really troubles us, because we know that if we proceed when we don't think they've really heard what we were trying to say to them, there's a high probability in our mind that we're going to have a successful operation with an unhappy patient.
And that's
that's terrible.
That's a horrible thing. Yes.
This is elective surgery. We're not saving anybody's life here. We're trying to make them feel better. So if people don't feel better from the process, that's a failure.
And I do find that a significant portion of the time of my consults are just trying to get expectation versus reality and try and find some common ground for the two. And it's usually, I think this is true for both of us. We're both starting from a very conservative starting point and trying to bring people, because most people come in going, I want a very aggressive outcome, and that's not always the best. I mean, it may be appropriate in certain scenarios, but it's trying to to make sure that the expectation meets reality will usually make for a happy outcome going forward.
So I hope this episode has been helpful to give you another example. We will continue to do further case studies going forward, so you can get a feel for it. We also would say to you that if any of you out there who live in Melbourne want to come in and do a live consultation with us and are prepared to do it on camera so that we can talk you through, the advice will be exactly the same as if you saw us privately. But if you are happy to come in and do it as an educational exercise for others, rather than just for yourself, we're more than happy to do that on a future episode. That would be a no-cost consultation to you. The details of how to contact the clinic to be involved in it, if you wish, will be supplied with the episode.
Yeah, we'll put that in the description below. Hope you found that useful, and we'll see you on the next episode.
Take care.
Thanks.